This talk is about dementia. Here are the class objectives. You do not need to read them. We will use them to chart our talk. The talk will be conducted using conversational and question and answer formats. First question. Dementia constitutes a problem with arousal. A true, B false. The mental status has two components. One is arousal and the other one, content of consciousness. I will now mention a type of arousal failure that we need to distinguish from dementia. Delirium. Delirium is characterized by an acute, relatively mild failure of arousal. The patient with delirium is not usually aroused by normal stimulation, but a strong stimulus manages to produce an arousal. Once aroused, patients with delirium display abnormal content of consciousness, characterized by a confusional state. The confusional state in patients with delirium manifests by disorientation, trepidation, illusions that result from misinterpretation of a stimuli, and hallucination, that is, incorrect perception not related to any stimulus. In this drawing, the magenta structure is the ascending reticular activating system. The arrows indicate the two-way communication between the cortex and the ascending reticular formation. Patients with delirium have bilateral patchy cerebral cortical dysfunction. Cerebral dysfunction is here represented by the patchy areas colored yellow. That's it. Thank you. The magenta structure is the ascending reticular activating system. The arrows indicate the two-way communication between the cortex and the ascending reticular formation. Patients with delirium have bilateral patchy cerebral cortical dysfunction. Cerebral dysfunction is here represented by the patchy areas colored yellow. Delirium is usually seen early in the course of metabolic diseases destined to produce more severe type of arousal failure, but it can also occur early in association with structural lesions. Dementia, on the other hand, is also a problem with mental status, but not with arousal. Dementia implies a content of consciousness alteration. The altered content of consciousness in dementia patients manifest by a disruption of cortical function involving memory and at least one or more cognitive domain. The disruption should be severe enough to produce significant social and occupational impairment. The disruption can be progressive, static, or reversible, depending on the etiology. A patient with dementia may have bilateral patchy or uniform bilateral cerebral cortical dysfunction. So the answer to this question is B. Next question. Between 60 and 90 years of age, the highest incidence of dementia is from 75 to 79 years of age. True or false? The numbers presented in this chart are from the United States. As you can see, from 60 to 64 years of age, the incidence of dementia is very low, 3.8 per 1,000 people. In the 75 to 79 year old group, the incidence is 18.7. Above 90, the incidence is 112 per 1,000 persons. So the answer to this question is false. Next question. Dementia in patients less than 65 years of age has the same causes as dementia in patients over 65 years of age. A true, B false. If we look at two sets of population, those with onset of dementia after 65 years of age and those with onset of dementia before 65 years of age. We can see that Alzheimer's disease, to which we are going to refer at times as AD, has a dissimilar distribution. Among patients with onset of dementia over 65 years of age, 54% will have AD. Among patients with onset of dementia before 65 years of age, 34% will have AD. I will now incorporate the three most common types of dementia after AD. As you can see in this frame, I have added a fifth group classified as others. Vascular dementia in patients older than 65 years of age represents 60% of all the dementias. In the younger group, it represents 18%. Dementia with Lewy body represents, in the older group, 20% of the cases, where it lacks representation in the younger group. On the other hand, frontotemporal dementia in the younger group represents 12% of all the patients with dementia, but it is not significantly represented in the older group. Other types of dementia constitute in the older group 10%, whereas in the younger group it represents 36% of the cases. So the answer to this question is false. Next question. Treatable causes of dementia should only be searched for in patients less than 65 years of age. A true, B false. If we go back to the pie charts, you can see a group labeled others. In this group, we have included treatable disorders. Treatable disorders are more common in younger than in older patients, but even after 65 years of age, you may find etiologically treatable dementias. This is a partial list of treatable conditions that can produce dementia. Stop the show, read it, learn it, write it down, and keep it handy for your word rotations. You will need it every time you see a patient with dementia. Among this list, at this point, I want to call your attention to Whipple disease. Whipple disease is a reversible dementia. Stop the show, go to YouTube, and watch this video. You can use your phone so you don't have to get out of this program. It is a very short video. Then return to this recording. The movement you have just seen are called oculomasticatory myorrhythmia. They consist of synchronous pendular vergence eye movements and contractions of the masticatory muscles. Oculomasticatory myorrhythmia is pathognomonic of CNS involvement by Whipple's disease. Whipple disease is a rare systemic infectious disease caused by the bacterium Trophidema whipplei. This is the abstract from the article in which this condition was first described. Here you can see a jejunal biopsy of a patient with Whipple disease. In it, you see red stained macrophage forming little red balls all over the place. So the answer to this question is B. Next question. Lacking clinical suspicion of a specific cause, the workup of dementia in a patient over and under 65 years of age should be the same. A true, B false. Based on the prevalence of the different types of dementia at different ages, the diagnostic workup of patients older than 65 should include all the following tests listed here. Stop the show and read them. Learn them, keep them handy when you go to the wards. Patients under 65 should have the same test done, but in addition, they should have slit lamp examination. A slit lamp examination is done looking for a thickened descent membrane due to deposition of copper. Thickening of the descent fibers indicates a nascent Kayser-Fleischer ring, which you can see here full blown. In addition to a slit lamp examination, younger patients should have copper studies, HIV serology, and if no cause is found after getting the prior test, you should consider specific metabolic studies and genetic screening, as well as muscle, axillary skin, marrow, and liver biopsies. So the answer to this question is false. Next question. Elevated CSF protein 14.3.3 supports the diagnosis of Creutzfeldt-Jacobs disease. A true, B false. According to some practitioners, CSF studies with manometry should be done in every patient with dementia during the initial evaluation, unless there is a contraindication to do so. According to others, not always. The later group of practitioners feel that in an older adult in whom you are certain they have AD, vascular dementia, or dementia with Lewy bodies, an LP does not have to be done routinely. Once CSF is obtained, all agree that it should always be sent for cell count, proteins, glucose, oligoclonal bands, gram stain, bacterial cultures, VDRL test, and India ink stain. This is how Cryptococcus neoformans looks in CSF using India ink stain. In addition, according to the clinical picture, CSF should sometimes be sent for special proteins, such as protein 14.3.3 and S100. High levels of these proteins support the diagnosis of Creutzfeldt-Jakob disease, but they are not specific for it. PCR should also be sent for viral panel, Wimple, and JC virus. The presence of high JC virus support the diagnosis of progressive multifocal leukoencephalopathy. Antigens for a specific organism should be requested. Antibodies for different organisms, including measles, should also be done. Cultures for suspected organisms should also be ordered. All these things that I just mentioned, they should all be done if there is clinical suspicion that the patient has one of these entities. So the answer to this question is A. Next question. The rate of deterioration can help distinguish among the different types of dementia. A true, B false. This chart maps time and intellectual function. Intellectual function referring to the general mental ability that includes reasoning, planning, problem solving, abstract thinking, comprehending complex ideas, learning quickly, and learning from experience. The course is divided according to time in acute, lasting weeks, subacute, lasting months, and chronic, lasting years. Alzheimer's has a chronic deteriorating course progressing in a matter of years. Vascular dementia also has a chronic course, but unlike Alzheimer's, in most cases of vascular dementia, there is a stuttering course, with periods of deterioration mixed with periods of stability. It is important to stress that the absence of a stuttering course does not exclude vascular dementia, as it is in the case of Binswanger's disease, a subcortical arteriosclerotic encephalopathy, usually associated with hypertension. Dementia with Lewy bodies tends to have a shorter course between subacute and chronic. The characteristic feature of the course of dementia with Lewy body is fluctuation. Patients with Lewy body dementia seem to deteriorate and then improve, but long-term deterioration is the rule. Encephalitis, including antibody-mediated Hashimoto's encephalitis and neurosycoidosis, if untreated, have a rather quick course. Creutzfeldt-Jakob disease advances in months. I will spend a few minutes on this disorder because despite its rarity, questions about it are often found in exams. Creutzfeldt-Jakob disease is associated with periodic discharges in the EEG, here labeled PD. It is a prion-related condition. CJD can be sporadic, familial, and acquired. CJD courses with dementia, startle myoclonus, and ataxia. CSF studies may be positive for the presence of 14-3-3 protein, as it was in this case. Microscopically, CJD is characterized by cerebral cortex spongiosis and neuronal loss. Amyloid plaques with a peculiar configuration are sometimes present. Some of the time, they join to form Halloween mask. The disease appears to be caused by accumulation in the brain of an abnormal prion protein denominated PRPSC. SC stands for scrappy, a sheep disease where the protein was first found. This abnormal protein is derived from the conversion of normal cellular prion protein denominated PRPC. This chart contains the common features of different dementias. This chart is similar to the one published in Neurology, a Queen Square textbooks in 2016. Stop the presentation and review it. I will be referring to it often during this presentation. The key feature of CJD, as we have mentioned, are periodic discharges in the EEG, startled myoclonus, and ataxia. After JCD, I want to bring up normal pressure hydrocephalus, because if untreated, it has a continuously deteriorating course, and if early detected, is totally reversible most of the time. So I am going to spend a few minutes talking about it. Normal pressure hydrocephalus is divided in two groups based on the presence or absence of a preceding event. In the absence of a preceding event, it is considered idiopathic. When a preceding event is present, it's denominated normal pressure hydrocephalus preceded by whatever the condition occurred before it. Subarachnoid bleed is by far the most common event preceding normal pressure hydrocephalus. Normal pressure hydrocephalus presents with a triad: dementia, gait disturbance, and urinary incontinence. Dementia is the result of frontal lobe compression, hence it has all the manifestations associated with it. Gait disturbance is the result of cerebral leg fibers involvement. I will explain how it happens. In a normal person, leg fibers, due to the position of the motor homunculus, here represented as magenta lines, travel close to the lateral ventricle. Those for the arms further, and those for the face even further from the ventricles. In a person with normal pressure hydrocephalus, the enlarged ventricles compress the leg fibers as they travel towards the internal capsule, producing weakness and spasticity, and in addition a peculiar gait. This gait is called magnetic gait. Go to YouTube and watch this video, then after continue the presentation. The third element of the triad is urinary incontinence. To understand how urinary incontinence develops, it is important to know that in the cerebrum we have two urinary related areas. One in the lateral surface of the prefrontal region of each hemisphere, and another one in the mesial surface of each hemisphere in the supplementary motor area. In this new diagram of the brain, the spine and the bladder, I have listed the two previously mentioned areas and the major loops involved in bladder control. The two brain centers form a polysynaptic circuit with the pontine micturition area. The pontine micturition area also forms a polysynaptic loop with the caudal structures, which ultimately control bladder function. By way of sympathetic neurons at the level of T10 and L2, and the sacral micturition area, which hosts parasympathetic and somatic neurons. A lesion in the brain, as indicated by the cross, the alleged site of involvement with normal pressure hydrocephalus, produces an uninhibited bladder. In a normal person, the fibers from the supplementary motor area travel close to the ventricles to reach the internal capsule, just as those for the legs. In a patient with normal pressure hydrocephalus, those fibers are stretched or damaged. The consequence is an uninhibited bladder. The mnemonic for these findings is wacky, wobbly, and wet. In addition to this triad, patients with normal pressure hydrocephalus have hydrocephalus with very peculiar characteristics. Crowding of the sulci at the vertex, that is, no increase in supranuclear space volume on the top part of the brain. Sylvian fissure widening, which indicate widening of the supranuclear space in that region, and ventriculomegaly, most prominently involving the lateral ventricles. It is important to stress that the CSF pressure is normal, although episodic increase in CSF pressure in these conditions has been reported. Normal lumbar puncture opening pressure in a flexed lateral decubitus positions ranges from 5 to 25 centimeters of water. These patients' CSF opening pressure is usually quite low. This frame put forward two possible mechanisms for the production of normal pressure hydrocephalus. One starts with reduced reabsorption, the other one with periventricular white matter ischemic changes. Both end up with increased CSF pressure, followed by ventricular dilatation and ventricular parenchymal compensation, leading to normal CSF pressure. Now I have reintroduced the course chart so you can take a look at it before going back to the current question. So the answer to this question is A, true. Next question. Which of the following elements is not intracellular? A, Uranobodies, B, Lewy bodies, C. Neurofibrillary tangles. D. Big bodies. E. Senile plaques. Irato-bodies are found in the hippocampus, most prominently in the CA1 region. Irato-bodies occur in AD, but also in other types of dementia. They are rod-shaped eosinophilic filaments, cytoplasmatic inclusion. Lewy bodies are round eosinophilic intracellular inclusion, often found in cells harboring neuromelanin. They are associated with primary Parkinson's disease, Lewy body dementia, and multiple system atrophy. They may be found in substantia nigra, locus coeruleus, and cortex. Neurofibrillary tangles are fibrillary arginophilic cytoplasmatic inclusions. The inclusions have a variable shape. Neurofibrillary tangles are present in Alzheimer's disease, aging, Down syndrome, dementia pugilistica, and postencephalitic Parkinson. Big bodies were called so because they were found in patients with Pick's dementia. In today's terminology, Pick's dementia is referred to as frontotemporal dementia behavioral type. Big bodies are intracytoplasmatic spherical inclusions. Big bodies are made of clumps of misfolded tau or ubiquitin proteins. One of the proteins in the ubiquitin clumps is called transactive response DNA binding protein and has a relative molecular weight of 43 kDa. This protein is often referred to as TDP-43, T for transactive, D for DNA, and P for protein. The 43 is for the relative molecular weight of the protein. Senile plaques are extracellular deposits of amyloid beta protein. They are found in Alzheimer's disease, but also in much less extent in normal aging. So the answer to this question is E, senile plaques. Next question. A 75-year-old man with progressive cognitive decline, fluctuating cognition with a 24-hour period, cognitive slowing, recurrent visual hallucination, and complex and bizarre, often violent sleep-related behavior is likely to have dash dementia. A. Alzheimer's. B. Lewy bodies. C. Frontotemporal. D. Vascular. The patient's age makes it likely that he's suffering from one of the big three: AD, vascular dementia, or dementia with Lewy bodies. The history of fluctuating cognition within a 24-hour period suggests, as represented in this chart, dementia with Lewy body. Having used age and course as guide to the diagnosis of the type of dementia, we must now look for supporting or contradicting facts to this tentative conclusion. This is done by comparing the findings in the vignette with the known features of the suspected disease. To do so, in case of dementia, I like to make use of the chart I presented to you before. As you can see in this chart, the terms Lewy body, dementia, and Parkinson's disease are together. This is so because Lewy body dementia is highly linked to Parkinson's disease, and long-standing Parkinson's disease patients develop Parkinson's dementia. Lewy body dementia is defined by onset of dementia with the features consistent with it in a patient without motor signs of Parkinson's disease, or arbitrarily defined by the onset of Lewy body dementia manifestations occurring within 1 year of the onset of the motor manifestations of Parkinson's disease. Dementia starting 1 year after the onset of the motor manifestation of Parkinson's disease is considered Parkinson's dementia. Be it as it may, you can see that this chart lists fluctuations as one of the characteristic conditions, a fact that we have already mentioned. So, in addition to fluctuation, the vignette lists cognitive slowing. Cognitive slowing referred to the slowing in reaction time, taking too long to answer a question or to initiate a movement. Cognitive slowing is usually noticed while the patient performs elementary motor tasks. Cognitive slowing is attained by historical information or during physical exam. During the physical exam, the patient is asked to tap with the dominant hand index finger as many times as possible for 10 seconds. And then after having finished this task, the patient is asked to tap after verbal cue. Patients with cognitive slowing have a long interval between spontaneous tapping, but tap consistently after every verbal cue. The second step is important in order to make sure that the slowing is not attributable to a lack of understanding, lack of attention, or physical impediment. Going back to the chart, we can see that cognitive slowing is not a feature of AD, at least not early on, nor is it common in frontotemporal dementia. But it is a feature of vascular dementia and Lewy body dementia. So, the presence of cognitive slowing in this vignette supports the diagnosis of Lewy body dementia. Another feature in this vignette is recurrent visual hallucinations. Going back to the chart, you can see that visual hallucination is a frequent finding in Lewy body dementia and rather uncommon in other types of dementia. The last element in this vignette is complex and bizarre, often violent sleep-related behavior. As you can see, REM sleep behavior disorder is common in patients with Lewy body dementia. So the answer to this question is B, Lewy body dementia. Next question. Which of the following findings is less likely to indicate cortical dysfunction? A, REM sleep behavioral disorder. B, visual hallucinations. C, acalculia. D, Broca's aphasia. Go to YouTube and look at some REM sleep behavioral disorder videos. Despite the poor quality of the video, I like the one in this frame, but there are many others that you can actually look at. REM sleep behavioral disorder is better understood if we understand normal REM sleep physiology. Normally, during REM sleep, rapid extraocular movements, as you can see here and here, shin EMG tone is low, and legs do not move. This is so because normal individuals during REM sleep activate an area below the locus coeruleus called the locus subcoeruleus area. Activation of the locus subcoeruleus working through the brainstem reticular formation and spinal interneurons act upon lower motor neurons in the spine and brainstem motor neurons to produce atonia in most muscles. Here I am pointing to an spinal cord motor neuron. Activation of the locus subcoeruleus leads to lower motor neuron hyperpolarization, which behaves like an electrical block, producing muscle atonia. I have in this frame represented this process in the spine, but a similar process occurs in the brainstem, thus producing atonia in most brainstem innervated muscles. Muscles spared from the influence of the locus subcoeruleus are the extraocular muscles, the diaphragm, the tensor tympani, and the stapedius. Hence, as you can see in this frame, while extraocular movements are active and we're dreaming, shin EMG and leg EMG are flat, reflecting the hyperpolarization of motor neurons in the hypoglossal nucleus and the leg spinal cord motor neurons. Contrast this tracing with this tracing, the one that I'm showing you now. In it, you can see rapid extraocular movements, high in chin EMG, and leg movements. The later two findings indicate lack of the physiologic motor neuron hyperpolarization that occurs during REM sleep. It is this lack of motor neuron hyperpolarization that leads to a person acting out their dreams, a condition as you know called REM sleep behavioral disorder. I will now make some comments about visual hallucination. Visual hallucinations result from involvement of the visual association cortical areas represented here. Patients with visual hallucination related to places probably have involvement of the dorsal or WEAR pathway in the parieto-occipital cortex. Patients with hallucination related to what or who tend to have involvement of the ventral or what pathway in the occipital temporal region. The more anterior the involvement in this pathway, the more complex the visual imaginary is. Stop the presentation and take a few minutes to review the position of the different gyri in the anterior region of the temporal lobe. In this new frame, look at the position of the perirhinal and the entorhinal cortex. Behind the entorhinal cortex, we have the parahippocampus. Behind the parahippocampus gyrus, we have the lingual gyrus. And lateral to the parahippocampal gyrus, the fusiform gyrus. Acalculia, another of the possible answers in this question, in Broca's aphasia are considered produced by cortical dysfunction of the dominant hemisphere. So the answer to this question is A. Next question. Which of the following condition is considered a subcortical dementia? A. Alzheimer's dementia. B. Frontotemporal dementia. C. Semantic dementia. D. Huntington disease dementia. Based on the region maximally involved, dementias are considered cortical or subcortical. Cortical dementias present with aphasia, agnosia, acalculia, apraxia, and visual spatial abnormalities. Among cortical dementias, we have AD, the behavioral variant of frontotemporal dementia, formerly called Pick's disease, semantic dementia, progressive non-fluent aphasia, and posterior cortical dementia. Subcortical dementia courses with cognitive slowing, apathetic behavior, and movement disorder. Subcortical dementias include Lewy body dementia, Parkinson dementia, and Huntington's disease dementia. Huntington disease courses with enlargement of the frontal horn of the lateral ventricle, mainly due to atrophy of the head of the caudate. This atrophy is due to neuronal loss in this structure. Huntington disease, an autosomal dominant condition, is characterized clinically by choreiform movements. In addition to Huntington disease, other subcortical dementias are vascular dementia and prion dementia, including CJD. So the answer to this question is D. Next question. The alien hand phenomena most often occurs in A. Alzheimer's disease, B. Frontotemporal dementia, C. Corticobasal dementia, D. Huntington disease dementia. The distinction between cortical and subcortical dementia is not always sharp. In reality, all cortical dementia have some finding characteristic of subcortical dementias and vice versa, especially later in the course of the condition. But there is one condition that manifestations are so evenly distributed between cortical and subcortical structure that it is called corticobasilar degeneration. Corticobasilar degeneration presents with features of cortical dementia and features of subcortical dementia, including motor abnormalities. Patients with corticobasilar dementia often develop a symptom called alien hand phenomenon. Alien hand phenomenon, in case of cortical dementia, refers to an involuntary motor activity of the limb, usually the hand, probably related to a striatal pathology in conjunction with the feeling of estrangement from that limb. The latter likely due to involvement of the parietal cortex or the area just below it. It is more often the right parietal cortex than the left, and it's considered to be a disconnection syndrome. So the answer to this question is C. Next question. Which of the following dementia is less likely to course with finding of frontal lobe involvement? A. Alzheimer's disease, B. Frontotemporal dementia, C. Normal pressure hydrocephalus, D. Huntington disease dementia. If we take a brain and divide it in thirds, we can adjudicate the different type of dementia, preferably involving the posterior region, such as posterior cortical atrophy and dementia with Lewy body. In the parietal temporal region, AD and corticobasilar dementia, and in the frontal region, frontotemporal dementia, normal pressure hydrocephalus, and Huntington dementia. So the answer to this question is A. Alzheimer's disease. Next question. A patient with fluent speech and preserved repetition but progressive anomia and loss of word comprehension that read using genetic pronunciation rules is likely to have A. Alzheimer's disease, B. Frontotemporal dementia behavioral type, C. Semantic dementia, D. Progressive non-fluent aphasia. As you can see, we're back to the dementia chart. Patients with AD have episodic memory loss early in their disease course. As you know, episodic memory refers to the memory of autobiographical events. Episodic memory is a form of explicit or declarative memory stored in the long-term memory compartment of the cerebral cortex. In addition to episodic memory loss, as the disease progresses, patients with Alzheimer's develop some speech comprehension problems, but speech production, at least until very late in the course of the disease, is preserved. In semantic dementia, episodic memory is not involved. Patients with semantic dementia lose semantic memory. Semantic memory is explicit or declarative memory. Explicit memory is considered long-term memory. Somatic dementia initially manifests by problems with speech comprehension. Semantic dementia is currently classified as a form of frontotemporal dementia, which is divided in those affecting behavior, called frontotemporal dementia behavioral variant, formerly called Pick's dementia, and those with primary language problems, which include progressive non-fluent aphasia and semantic dementia. Semantic dementia courses with anomia, knowledge of words and knowledge about words is lost, fluency is preserved. The patient with semantic dementia will read out loud using general rules of pronunciation and not rules specific for a given word. They would read tooth and teeth, so when they read rude, they read reeds instead of roots. Patients with semantic dementia sound like progressive Wernicke's aphasia with normal repetition that goes on to become demented. PET scan in patients with semantic dementia have shown bilateral temporal lobe hypoperfusion, the left being more affected than the right. In progressive non-fluent aphasia, the patient redacts grammatical sentences, loses speech fluency, or both. Repetition of words and sentences is also affected. Understanding of single word is normal, but understanding of complex and sequence instruction is minimally involved. Progressive non-fluent aphasia resembles a progressive Broca with some understanding issues. PET scan shows hypoperfusion of the left inferior frontal, insula, and perisylvian area in most cases. In addition to these two forms of primary progressive aphasia, there is a third type of primary progressive aphasia called logopenic dementia. Logopenic dementia is a very interesting condition. Naming is bad. If you show a picture of a dog, a patient with logopenic dementia cannot find the word for it. Single word repetition understandings are good, but full sentence repetition understandings are very bad. Speech is fluent. What makes this condition interesting is that it appears to be a problem with working memory. They can understand the first word in a sentence, but by the time they hear the third word, they have forgotten the first one. Working memory is the memory that allows you to remember what you are doing as long as you are not changing task. If you have any difficulty understanding memory, review the presentations about memory. It is this memory that is affected in these patients. Now I want to talk to you about behavioral variant of frontotemporal dementia, the most common type of frontotemporal dementia. Patients with this condition have changing personality, impaired judgment, apathy, loss of empathy, loss of appropriate social behavior, but relatively preserved memory. So the answer to this question is C. Next question. Approximately dash of frontotemporal dementia cases have a family history of the disease. A, 5 to 10%, B, 11 to 19%, C, 20 to 40%, D, 60 to 80%. Frontotemporal dementia is fundamentally a disease of the young. If you consider someone less than 65 years of age young, 20 to 40% of the time a family member has been affected by it. Frontotemporal dementia in 10% of the cases is due to an autosomal dominant condition. Mutation producing frontotemporal dementia is often found in chromosome 17. So the answer to this question is C. Next question. A dementia syndrome with any of the following: sudden onset, focal neurological sign, or seizures or gait disturbances early in the course of the illness should be classified as A, unlikely Alzheimer's disease, B, possible Alzheimer's disease, C, probable Alzheimer's disease, D, definite Alzheimer's disease. This set of criteria is from the National Institute of Neurological Diseases for Alzheimer's disease. Stop the presentation and read each of these elements. After you finish reading it, continue rolling. Notice that the definite diagnosis can only be made with histological confirmation. Also notice that sudden onset, focal neurological signs, seizures, or gait disturbances early in the course of the illness makes a diagnosis of Alzheimer's unlikely. I think that when they refer to focal neurological signs, they refer to motor and sensory signs, to the exclusion of loss of episodic memory. So the answer to this question is A. Next question. Which of the following structures is most likely affected in a patient with Alzheimer's disease? A, head of the caudate, B, hippocampus, C, substantia nigra, D, amygdala. Huntington disease dementia occurs with enlargement of the frontal horn of the lateral ventricles. This is due primarily to atrophy of the head of the caudate nucleus. Huntington disease is an autosomal dominant condition characterized clinically by choreiform movements. These movements usually precede the sign of dementia. Alzheimer's disease produces hippocampal atrophy that translates into enlarged anterior regions of the temporal horn of the lateral ventricles. The process of hippocampal atrophy is progressive, as you can see by comparing the size of the anterior region of the temporal horn of the lateral ventricle in an early study to the size of the same structure 1 year later. These are two transverse sections of the midbrain. In the normal specimen, you can see the dark pigmentation of the substantia nigra. In the specimen from a Parkinson patient, you can see the lack of pigmentation of the substantia nigra. In Kluver-Bucy syndrome, you can see the hole at the location of the amygdala and the preservation of the hippocampus. I have now introduced a specimen in order to show you their position. This specimen is from a normal brain. Notice the position of the amygdala and the hippocampus, the amygdala being in front of the hippocampus in this cut. So the answer to this question is B. Next question, which of the following decreases the risk of Alzheimer's disease? A. More ApoE2, B. More ApoE4, C. Increased amount of amyloid precursor protein, D. Mutation in the presenilin genes. The most prevalent hypothesis about the pathogenesis of Alzheimer's disease has a black sheep. The name of this black sheep is amyloid beta. An increase in amyloid beta produces tau hyperphosphorylation, turning a good microtubular glue called tau to a bad glue called hyperphosphorylated tau. As a result, microtubules get on glue and break apart, forming neurofilament tangles and disrupting cellular transportation. In addition, amyloid beta agglutinates extracellularly, disrupting neuronal transmission and forming senile plaques, and furthermore, increased amyloid beta produces neuronal degeneration, especially in the basal nucleus of Meyers, producing cholinergic dysfunction. In this frame, you can guess the location of the nucleus of Maynard by knowing the myelin structures close to it. Notice the color of the arrows. They are color matched with the names in the legend. The histological specimen was obtained using a myelin stain. Even when the area examined is restricted and the histological specimen enlarged, the nucleus of Maynard cannot be clearly seen because, again, we're using myelin stain. Using a neuronal stain in the specimen just added allows us to see the nucleus of Maynard bilaterally. The question regarding the pathogenesis of Alzheimer's disease is why amyloid beta increases. Amyloid precursor protein is a normal component of neuronal cell membrane. Hence, when all needs to be disposed of, disposing by the way of cleavage occurs by the action of three secretase produced by presenile genes. Alpha and gamma secretase cleavage amyloid precursor protein and produce small manageable parts that do not accumulate. On the other hand, amyloid precursor protein that is cleavaged by beta and gamma secretase forms large structures called amyloid beta that accumulates. Apolipoprotein E2, 3, and 4 are part of the mechanism and appear to be the limiting step in removing amyloid beta. Apoprotein E2 removes a lot of amyloid beta, whereas apoprotein 4 removes very little. So going back to the question of why amyloid beta increases, the causes of increase of amyloid beta are increased amount of a normal cell membrane protein called amyloid precursor protein, from which amyloid beta comes from, as occurs in patients with Down syndrome, increased cleavage of APP by beta-gamma secretase, which occurred with mutation of the presenilin genes, high levels of ApoE4, the bad remover of amyloid beta, and low levels of ApoE2, the good remover of amyloid beta. So the answer to this question is A. Next question. A mini mental status scale of 10 points is consistent with dash dementia. A, mild, B, moderate, C, advanced or severe, D, no. In this frame, you can see a mini mental state examination exam form. This mini mental state examination form can be gotten for free at Oxford Medical Education website. The mini mental examination is a convenient complementary tool to diagnose and follow patients with Alzheimer's dementia. Please stop the show and read advantages and disadvantages of it. In this new frame, you can see the different items included in the mini mental status examination. Again, stop the presentation and familiarize yourself with the instruction and the scoring guidelines. And a score of 23 points or below is consistent with Alzheimer's disease. This graph represents the likely progression of patients with Alzheimer's disease as measured by the mini mental status examination criteria. The course of patients with Alzheimer's disease has traditionally been divided into mild, moderate, and advanced. As you can see here, from 23 to 20 is considered mild. At this stage, episodic memory is usually first affected. By the time the score is 19 to 13, the impairment is easily noticeable because other cognitive parameters are affected. Behavioral changes are present relatively late in the course. Yet there are other classifications as the one presented here from Oxford Education, but in all, a score of 10 is considered severe. So the answer to this question is C. Next question. Mild cognitive impairment refers to a condition characterized by dash complaints that are mild and do not interfere with daily function but are still disproportionate for the patient's age and education. A, memory, B, judgment, C, intelligence, D, speech. In mild cognitive impairment, the deficit is restricted to memory. When other aspects of mental functioning are affected, the term such as aging-associated cognitive decline are used unless other factors suggest AD. It is important to know that 10 to 20% per year of those patients with mild cognitive impairment will develop Alzheimer's disease. Hence, when a practitioner feels, based on family history and other factors, that the mild cognitive impaired is due to Alzheimer's disease, the term prodromal stage of AD is used. The job of a doctor in patients with mild cognitive impairment is to be reassuring, concerned, and cautious. Sometimes this means, in addition to careful and often neurological evaluations, doing a mini mental status exam, MRI of the brain, PET scan, or even lumbar punctures for regular and targeted studies including amyloid and tau. Above all, you must consider and eliminate treatable conditions capable of producing similar findings. Treatment of patients with mild cognitive impairment consists of advising the patient to keep busy with intellectual pursuits, to maintain healthy living habits, put life in order, and to control blood pressure and cholesterol. Cholinesterase inhibitors, the only drug approved to treat Alzheimer's disease, should be considered. So the answer to this question is A, memory. Next question. A patient with poor effort during mental status testing, frequent I do not know, and impaired memory that improve with cueing is likely to be suffering from A, Alzheimer's disease, B, depression, C, delirium, D, transient global amnesia. The table in this frame contrasts Alzheimer's and depression. Stop the presentation and read it. All features are relevant, but the fact that memory is not helped by giving clues in Alzheimer's, but does improve by giving clues if the patient is depressed, is of particular importance. I'd like to finish this presentation by telling you a few words about transient global amnesia. Transient global amnesia is one of the most peculiar conditions we see in neurology that has a good ending. Not much as to what goes on in the brain during it is known. Transient global amnesia is sometimes triggered by strong emotions, but in most cases it comes out of the blue. Stop the video and read the statements in this frame, and then go to YouTube and watch this video. So the answer to this question is B. Thank you very much for your attention.